Welcome everybody to the 26th annual John H.P. Maley Lecture. In 1996, the Maley Lecture was established to honor a member of the American Physical Therapy Association who has made a significant contribution to the profession in the area of clinical practice. Today, I'm proud to announce this year's recipient is Dr. Timothy Flynn. Tim is a professor of physical therapy at South College in Tennessee, a world-renowned clinician dedicated to providing the highest quality care possible at Colorado in Motion. His primary clientele includes clients suffering from chronic spinal pain, failed back surgeries, and chronic health disorders. Tim is also the author of more than 100 peer-reviewed articles, books, and book chapters, and both a Catherine Worthingham Fellow of the American Physical Therapy Association and a Fellow of the American Academy of Orthopedic Manual Physical Therapists. Though the list of Tim's accomplishments is impressive, he may be best known as an outspoken advocate for patient-centered care and an insightful critic of medical systems that, in his words, are based on models of, quote, doing to people and selling sickness, end quote. Today, Dr. Flynn's lecture is titled, Why We Must Leave Medicine to Create Healthcare. It's more than a timely subject. It's a topic that must be addressed as we continue to struggle with the mismanagement of pain and other conditions through pharmaceutical and surgical approaches that in many instances put patients last, not first. Please join me in welcoming Dr. Tim Flynn.
You know, I was born in a small town in South Dakota, and Sunday afternoons, they truly were the best because there was that ritual that happened on Sunday, that being football. Of course, in our family, we'd come home from church, and as the bacon smells still waft through the air, we would dutifully clean up the kitchen, bring the dishes out, and then my father and us would sneak out into our small family room, which had a black and white TV. My father would sit down, kick back in his easy chair, and he would begin to look at CBS, because on CBS was a Central Division. Of course, on the Central Division, we had the Minnesota Vikings and their daunting purple people eater defense. You know, my father, he would reel off all the names of them, and his smile would go broadly across his face. But typically, by the second quarter, I would hear this familiar rumbling. And this particular Sunday, it was in September, it was warm, and my father had kicked off his shoes that day. And as he slept next to me and I played with my Lincoln Logs, I looked up. And it struck me that I knew exactly what to do. You see, my father, he was a very mischievous man, and he passed that on to me. And so as I sat there, I looked up, and these large feet loomed next to me. And I reached up, and on the inside arch of his left foot, I went like this. My father jumped up, he yelled, screamed, no, no, no. My mother came in from the other room. I froze, and she said, don't ever do that to your father again. My dad placed his hand on my shoulder, and as I looked up, I saw the fear recede from his eyes and his respiration rate slow. He said, don't worry, son, it's okay. You know, it would take me many years and perhaps a lifetime to understand what happened that Sunday afternoon. I would go on to learn about my father, a modern-day Lakota warrior, a highly decorated Marine Corps aviator who unfortunately, on his last mission over North Korea, was shot down. For the next 16 months, he was in a POW camp, high-value target. After months of solitary confinement, pulled out and began sleep deprivation and brutal, brutal torture throughout his body, and yes, to the bottoms of his feet. You know, we all have different perceptions about pain. Whether you're a POW, an 8-year-old boy, or an executive. But this I know to be true. Our society's beliefs about pain are killing us. And the modern US medical industrial complex has created, promoted, and sustained this epidemic in pain. And I believe the words of Hoyt Axton, actually made popular by Steppenwolf, will rapidly get us through how we got this way. I think most of us know the story, but if you just give me a minute, let's just look and listen to the story of where we are today. You know, to be fair, it's not just the pharmaceutical industry. Let's take a look at just one surgery, and let's look closer at the surgical and device manufacturing industry and now how they continue to promote their wares. In these slides, we're looking at the trends in lumbar fusion procedures. And this was from 2004 to 2015. And though you may not be able to totally see on the graph, what you're seeing in this period of time, this is age across the x-axis, and that's the rates per 100,000. But from 2004 to 2015, you see these massive increased rates in spinal fusion surgery, but it's with our most oldest, vulnerable, and highest risk population. Of course, one procedure alone, in terms of at the end of 2015, cost $10 billion for one orthopedic surgical procedure, $10 billion spent in our country. You know, it'd be nice if it was shown to have high quality outcomes, but multiple studies, including 3 randomized controlled trials out to over 12 years, have shown that there's no benefit to lumbar spinal fusion surgery when used for individuals with chronic low back complaints. You know, we've had multiple studies, many starting nearly 2 decades ago, that have looked at the combination of using our hands with manual manipulative therapies, using exercise, and how they improve patients' physical function, walking capacity, and most importantly, decrease their need for further medical care. You know, it'd be one thing if you could actually say who you should do this on. But in this study, they took standardized cases. So you had the MRI, you had the history and physical examination of these patients, and board certified fellowship trained spine surgeons were given this and asked, how would you manage this condition? Well, 75% disagreed with what surgical approach they would do, whether they would do surgery, or how many injections they may need. Stunning. You know, I think we'll look back, much as we did with the neurologist Egas Monez, whose operation truly was, at the time, a great therapeutic step forward. But I think we would look back now and say, you know, is truly spinal surgery for low back pain, the lobotomy of our time. It's not just back pain, something I know I'm very familiar with from a physical therapist perspective, but we've seen randomized controlled trials that have shown really that there's no difference between surgery and non-operative care in arthroscopic ACL reconstruction, partial meniscectomy, acute rotator cuff tears, subacromial decompressions, and spinal decompression surgery. No difference. Yet I would argue how many of those come into our clinic every day. And even our favorite of all, hip replacements, have not really been subject to randomized clinical trials, nor have meniscal repairs. Yet we do them routinely throughout the country. It's always about risks and harms, right? If there was no risk, then why are we having this conversation? But what we do know that orthopedic conditions are the #1 reason for surgery. And what this Lancet paper showed that covert stroke occurred in 1 in 14 patients over the age of 65 undergoing a non-cardiac surgery. And orthopedic surgeries were the main surgeries. And a year later, they were at increased risk of cognitive decline. 1 in 14. These are not trivial numbers. You know, the modern US medical industrial complex has created, promoted, and sustained an epidemic in pain. Can we fix it? Well, we have the solution, and I know many of you know it, and it starts with barriers to access. We know that indeed, low back pain, one condition, is the #1 reason for an opioid prescription. But what happened? What actually happened when this is running out of control? This paper published in 2017 looked at the number of low back pain visits over about a 15-year period. And what they found was low back pain visits in this gray continue to go up every year. And lo and behold, in green, these opioid prescriptions are going up every year. And oh, by the way, physical therapy referrals, they're going down or remaining stagnant. Stunning. I always say where you start is where you end up. If you happen to stumble into a physical therapist's office, your outcomes for low back pain are going to look pretty good. If you happen to enter through the traditional medical route, I don't care where it is, where it's a primary care office, whether it's an ER, whether it's any type of quick clinic, the outcomes don't look nearly as good. We started on this journey with a number of my colleagues that really looked at, what happens when referrals to low back pain from primary care providers. Back then, we found only 7% of patients received PT within 90 days. This is for a low back pain episode of care. If you actually got PT early, got it within the first few weeks of problem, you had a decreased risk of advanced imaging, physician visits, surgery, injections, and opioid use as compared with delayed PT. And oh, by the way, it was cheaper. Okay. But that's not what we see. Now, these studies have been replicated by multiple authors in multiple different types of settings. This was with episodes of care, over 750,000 episodes of care in the DoD system. And what it said is if this is our index rate, those that got PT within the first few weeks of their episode of care, decreased opioid use, decreased injections, surgery, and advanced imaging compared to delayed PT. And these are dramatic. Again, we know the harms of those types of procedures, both patient harms and financial harms to our system. This is not just in the areas excuse me, I'll give you one more in low back pain. This is again looking in 2018, showing the total medical costs of early PT, nearly $3,500 lower for those that got into physical therapy early. Again, opioid use down, injections down, surgery way down, advanced imaging down. And this is with nearly 47,000 episodes of low back pain. We see the same thing when it comes to neck pain. This is a little bit different graph, but just if in this time the index is people getting early physical therapy and those compared to delayed or late physical therapy in red. The bottom line, if it's delayed, it costs $1,000, 63 higher. If it's very late, being 91 to 365 days, it was $2,100 higher than patients that got early PT. But the other thing to look at, this is opioid injections, MRI, X-ray, and CT. all of those higher risks to much higher risks down the line. So it would seem like multiple studies throughout the spine showing get folks in early. You know, it's not just the spine though. The odds for downstream healthcare utilization go up when it comes to individuals with knee pain. In this study, this is patellofemoral pain, and they showed similar things that are showing in the spine. And the costs of physical therapy first group was $1,100 lower, and it was it was lowest in that group and highest in the delayed physical therapy group. So again, the timing of care matters, okay? And why is it? One of the reasons is that if we get people in early to PT, often bad things don't happen. One bad thing is an MRI. You say, well, MRI, that can't be bad. Well, this paper published just recently published, looked at primary care providers. Again, these are primary care providers in the UK system, so not necessarily financial incentives to order more imaging like there is in our country, but just about 5% of MRIs appeared indicated based on review. That's 1 in 20 of the MRIs they sent them to. And only 16% received conservative care prior to imaging. Again, only 16%. And you say, well, pictures are cool. Well, what we know about pictures is they're not good when we're peering inside the body because we use scary words to describe what we see. In this slide here, this is the percentage, okay? And this is your age. Most of us in the room, you know, trend down into 30 or below, so you can just focus here. For some of the rest of us, we have to focus more in the upper quadrants of the room. So first and foremost, none of these people getting imaged have any back pain. Okay, they have zero pain when they're getting imaged. But this is what the radiologist says they have, okay? Disc degeneration. If you are over 60, it's basically 90%. So you are such an outlier if you do not have disc degeneration. And I would say you're pathological. I mean, 1 in 10, that's that. So clearly that's like normal stuff, right? Disc bulging, disc height loss, and these is facet degeneration as well, joint degeneration. Again, they don't have any symptoms. They're pain-free, but these are the labels they're given. So imagine if you have pain, you know you're gonna get one of those labels. You go in, you have pain, you get the label like, oh my God. I mean, we all hear it every time we go out. We can't go out as physical therapists, which is why I love our profession, because immediately, hey, what can you tell me about, you know, I just went and I had this back problem and I got facet degeneration. And Sue looks at me, I take a deep breath, and where do you begin? But I launch right into what I think. So, and I tell them right away, you know what? I've got wrinkles. I never had these prior to children, but I have these wrinkles. But you know what? A lot of them are from smiles, and currently there's zero pain. There's zero pain in them. You know, we also have these wrinkles on the inside, and these wrinkles on the inside are normal. That's just normal. We shouldn't call them bad words. So, you know, if you happen to get an MRI first before you see your physical therapist, here's what we know. You're 6 times more likely to have surgery, 5 times more likely to have an injection, and 4 times more likely to have an emergency room visit. Just ponder that. And we say ordering, you know, more information is better. You cannot argue that when it comes to MRIs and spinal pain. You know, of course, for those of us actually in the system out there, especially those of us in private practice, we know, you know, our friends, the health insurance companies, which have a lot of these buildings along this area as well, you know, they are increasingly cutting reimbursements for treatments that are shown to be effective and cost less money. Why is that? It just doesn't make sense. We keep beating our heads against the wall. That doesn't make sense. And then we think, Affordable Care Act, what did it do? It capped profit margins at 20%. So what do? You make sure you take big parties, so that's off your profit margin, right? Yeah, big parties, we'll take that off. But then you just got to spend more money, right? Because as premiums go up, what happens to your margin? Well, your margin stays at 20, but if your top line goes up, my bottom line goes up. So it makes way more sense to spend money on high dollar stuff if you're an insurance company. It makes no sense to try to save money. I mean, because our shareholders would not like that, okay? You know, this is a pharmacy slide, I really like. It basically says, this probably won't work, but we do have medications that will take care of the side effects. I mean, these commercials, I'm like, man, I mean, people just tune out the fact that not only are you going to poop your pants, you're going to not be able to poop. And, you know, I mean, it's crazy, but it's okay. But I wish they would just put this thing in there. Or you could see a PT. They're kinder, cheaper, and they won't kill you. I mean, it's a simple slide and a simple sign. Again, where you start is where you end up when it comes to healthcare, and particularly in the area of neuromusculoskeletal disease and disorders. You know, I often ask, you know, people, what do you see in this picture as you look at this number of medications sitting before? And what I often find is people will say polypharmacy, they'll say despair, they'll say confusion, frustration. And I say, dang, you are wrong. What I see is this person is getting a lot of our medical care in the United States of America. That's a lot of medical care there. I don't see much health happening. You know, what do we know about prescriptions now? We know that 36% of older adults are regularly using 5 or more medications or supplements. 15% potentially at risk for a major drug-drug interaction. That means fatal interaction. 15%, okay? And if we take it a step further, we know that half of all Americans are on prescription drugs. The average drug, again, number being 5. The average number being 5. You know, that counts the people prescribed the drug, right? That doesn't count the people that have access to the medicine cabinet of those that are being prescribed that drug. What we know is opioid prescriptions and family members are associated with overdose among individuals who do not receive opioid prescriptions. Their family members are at risk. And when you give these drugs, you say, oh, by the way, your family member is at risk if I give you this prescription. No, that usually doesn't happen in the conversation. Nearly 1 in 3 Medicare beneficiaries receive an opioid prescription or received an opioid prescription in 2015. 1 in 3. Okay. Now, let's take a look at this. This is fall-related mortality and fall risk increasing drugs among older individuals. And this is looking from 99 to 2017. On the top here, you have persons with at least one fall risk increasing drug. If you look at the top here, it's 94% over the age of 65 have at least one. Doesn't count the polypharmacy. Okay. Oh, by the way, the green line is deaths due to falls per 100,000 persons. And I know I apologize to all the academicians in the room. Correlation does not equal causation. However, over 700,000 hospitalizations are associated with unintentional falls. Over 700,000. Unintentional falls accounted for 91%, over 91% of injury-related hospitalizations, followed by unintentional motor vehicle crashes. Down at like 6%. Think about that. And I ask myself, which is more dangerous to an older adult? Their Medicare pharmaceutical benefit card or their driver's license? We continually take that card away, but I kind of wonder how much we're helping them with the other. We can't have this conversation without having the conversation of how the modern U.S. medical and agricultural industries are intimately entangled, and how they're entangled in the epidemic of pain, obesity, and chronic disease. Here we know that in 2019, $1.1 trillion was spent on food. We spent $1.1 trillion buying the food. But that doesn't include the $1.2 trillion cost estimates of the healthcare, or I should say medical care, for the millions who fall ill with diet-related diseases. We don't tax that, right? So double the cost of what we spend, we're spending on healthcare. And those things, if you look at obesity, about 360 billion. If we add all the other diseases that of cardiovascular disease, hypertension, cancer, and diabetes, another 600 billion. Food insecurity, 146, and then the impact of on pollution of our air and water. So that's what we spend in terms of money directly and what we're not accounting for. If we look at just one thing, let's say obesity. These are obesity statistics, and the projection is that probably by the end of this decade, if things continue, half of all Americans will be obese. Half. If you move to America, the risk of obesity and other chronic diseases goes up. You become less healthy when you enter our shores. Some groups increase a fourfold increase in obesity after 15 years of immigration to our country, that quickly. You know, what's happening? One of the hypotheses with increasingly more data is looking at, you know, the gut itself and what happens to the gut when we come to this country and it happens to our guts if we eat a traditional American diet. Well, first and foremost, if you're an immigrant, you come with a very healthy gut microbiome, very diverse microbiome that breaks down products, turns them into energies, that doesn't, it excretes them. But on new arrival, within months, if you compare, the gut microbiome begins to lose diversity, and then by long-term residents, more so, and by second generation, you basically look like everybody else. At the same time, the body mass index of those new arrivals goes up and looks just like America. So the gut microbiome is important. If it's been shown that diversity in the gut microbiome, you know, really has an effect on many things. And again, less diversity is bad, less diversity within that gut. And you find things like diabetes, depression, heart disease, colon cancer, inflammatory bowel disease, chronic inflammatory conditions, musculoskeletal pain, ADHD, seizures, asthma, and most importantly, in this current time, the severity of COVID-19. Again, it's not surprising that our immune system being within our gut, when it's not healthy, that's going to put us at greater risk when we have something like COVID affect us. Now, why is the agricultural industry tied in with this? Well, the big issue surrounds this primarily that of glyphosate, which glyphosate is the primary ingredient in Roundup and other herbicides. But glyphosate is an antibiotic. Okay, it's an antibiotic. Essentially, when it gets into our food system, it's an antibiotic. Antibiotics are really good at blowing out any type of diversity in your gut. It's pretty much broad spectrum, and it takes stuff out. Now you say, okay, well, how much are we using? Well, in this left-hand panel, this is actually per acre you're seeing the use. And in the deep dark red, it's about per square mile, it's 90 pounds of this being spread per square mile of agricultural land. Wheat being our worst product used with these sprayed on, wheat being sprayed by glyphosate. Before harvest, up to 8 times typically it is sprayed, because it's now Monsanto and others have engineered seeds such that they actually do well with it, and it makes them turn quicker to harvest, so they mature quicker. So literally they douse it up to 8 times prior to harvesting. And not only does that pesticide remain or herbicide remain on the residuals on the wheat product, but it also kind of ends up going down this thing called our waterways, and ends up going down the big waterway called the Mississippi. And the Mississippi, of course, in the Mississippi River Delta is known as Cancer Alley, right? Colorectal cancers. These are colorectal cancers, and you can see in bright red along the delta there. Again, it's got to go somewhere. It's spread and it flows downstream, and in much of the way we've done throughout our history, we often, those that have least access to higher ground and clean water are greatest affected. You know, there's a movement about them. There's a movement to really look back at, what has happened to our soils, how they've gotten just totally torched, and how can we restore our health. A couple big ones, The Dirt Pure and No Grain, No Pain. These books are talking a lot about the science behind getting to the root cause of these products that are literally affecting how we feel and literally how we think. And I often used to say, when I grew up, there wasn't all these sensitivities that we have, gluten sensitivities, peanut sensitivities, all these sensitivities, they were not part of growing up. It was an outlier. And now it's normal. I mean, it becomes normal that we have all these sensitivities. And one of the things I like to say is gluten sensitivity, a nice name for glyphosate toxicity. It's really these guts, when you look, they've been torched. And they're then taking in more toxicity if they're eating these type of products that have residual herbicides in them. Our profession is talking about this. This isn't new. This editorial just published this year really looks at, the fact that when it comes to education, that we really need to make sure we are teaching and have these modules within our teaching programs. This idea of planetary health, how the natural environment is related to health, and how these problems of colonialism, social justice, and health equity are intertwined, especially when you begin to look at our food systems. And we also, exercise and activity prescription models that really look at exercise and green space, and then of course, lifestyle health, really looking at what we do, how we do it, and how that affects our health. This, I believe, in our next 100 years, but I say we must do it within this decade. The physical therapist is a health professional who has an unwavering belief in the human spirit to overcome all obstacles. Physical therapists use physical, neurological, psychological, behavioral, nutritional, and other non-pharmacological means to optimize movement and create vibrant health from cradle to grave. If we think about that, how does that influence how we educate our next generation of physical therapists? Well, I think it's important to look at how physicians are being trained. This is current. The pharmaceutical industry is one of our key training partners for our physicians. Residents report on average, they get 6 gifts, 70 lunches, and 75 promotional items per year from the pharmaceutical industry representatives. Over 40% of emergency medicine departments allow residents to be taught by the drug company reps. That's their faculty. Clearly no conflict there. But you get your degree, you get your license, and you're board certified. Oh, now it really gets fun because every week you don't have to pack your lunch, right? At least one day a week, you're for sure going to get your lunch from the pharmaceutical reps. But I think this quote says it best to me. This was a colleague of mine who's the chief family medicine residency. And we were talking just earlier this spring and got on the topic that I often talk about, musculoskeletal pain and how poorly we treat it, and balance and falls, how poorly we're doing, et cetera, et cetera. Well, and he just said, he stopped me, he said, Tim, you don't understand. When a patient comes in to see me, I really only have one treatment tool. That's my prescription pad. Okay? This is a wonderful human being. He's trying to do the right thing. But the system is not doing the right thing, and the training of our next generation is not doing the right thing. So when it comes to educating and training our next generation, I'd like to digress just a little bit because I think a funny thing happened on the way to the DPT. First, I look at these places, and do these appear to be health-focused places where you want to educate your physical therapist? I'm not trying to offend, but I look at the medical industrial complex, and we're tied within that in many of our largest training institutions. And are we just kind of passively going along with how crazy this is? If you're a patient Is that where you want to access your care? You know, when you have had a fall and the ability to even get inside these places? Or do you want to go somewhere where your PT is on the corner where everybody knows your name? You know, is that where you want to go? You know, we can't talk about DPT education without student debt. Okay, that we got that. I want to challenge us a little bit to say, you know, cumulative net income. If we look at a student's cumulative net income, we know that they lose money during their years in PT school with debt, and they're accumulating debt. They're getting debt as they go on. But we know that when they get out, you know, they actually begin to earn money. And the key is, can they pay it off, right? Many are more smarter than me, but we do know that if we compare private universities, 3-year traditionals, publics 3 years versus hybrids that are 2 years, you know, you're going to come off better, quicker, because you're going to start paying your debt off much sooner. It's a basic equation, okay? But I think, so I'm actually very positive. I think the debt load issue, disruption is here, COVID accelerated, we're changing. We just have to accept that we're changing, and it's going to change. But I would challenge you, it's going to change even more, because I believe by 2030, what we'll see is, yes, we'll have the 3-year accelerated bachelor's program, health focus, that gets rid of a lot of things that are nice, and are okay. You can still go 4 years and make sure you, especially if you're in a place that has a good football team, continue to do that. But you can also get into DPT program much quicker. You can get through there quicker, and it will be health focused programs. These undergrads will be feeder farms to the next generation of truly health focused clinicians, not medically focused clinicians. So I really think disruption of COVID will fix this. That's my thought. But I also have some other deep thoughts when it comes to DPT education. And since I do have the stage, I get to do that. And then I get to hear about it. Oh, I don't believe that, which is cool. That's why we're here. You know, I often say, should DPT programs be on academic or real world clinical schedules? You know, you can't run a lab if it's twice a week at these weird hours when you have your best clinicians that actually can't get out of those clinics because they're doing good work to train our students. You know, our programs must be like the clinic, okay? You might, if you're in a lab, you need to be there all day, just like you're in a clinic all day. You know, I'd also say, would you rather have a non-practicing physician, PhD, if you happen to have surgery, you know, for those of us that might happen to have a surgery, would you rather have that non-practicing physician, PhD, train that surgeon? Or would you maybe want to have at least a surgeon kind of be part of that training program? So if you believe that, then should practicing clinicians or academics be leading our DPT clinical skills courses? You know, we have gotten so far removed to the altar of higher ed that we have to check these boxes. In fact, we own our profession. We're the clinicians. We own this profession, and that means our profession must look like clinical practice. And we must have our highest quality clinicians being part of those teaching courses. You know, do our faculty members practice and model behaviors? We tongue-in-cheek at South where I'm at, we say, take your meds. And it is tongue-in-cheek because it's take your meds means meditation, exercise, diet, and sleep. And every quarter students go through meditation. That's part of it integrated into the course. Exercise, you know, are we actually using devices, monitoring your change, coaching your partner, and seeing behavior change with data through that? What does your intake look like? Do you actually eat and are aware and understand the hidden sugars? You understand what you're actually putting into your body and how much is actually not food. It is a chemical. It's not a food substance. And teach about that, as well as sleep and rest and restoration. And as we know, the power of that to actually become smarter and to get not so smart with the lack of it, right? And really teaching that again through devices, monitoring to make sure you know how to do it on yourself. If you can do on self, you can then do and help others. But do our clinical sites do the same thing? Do they practice and model healthy behaviors? Where we're at, we used to use the acronym FRAME. What we mean by FRAME is fuel, so what we are eating, rest, okay, sleep, rest, activity, and activity, movement, fun, outside, being about in our community, mindfulness or meditation, whatever resonates, breathing, whatever resonates with your patient, and exercise being of the order of high intensity, aerobic, and those types of things. But what do you see in your frame, and how can we frame you to better health? This, I believe, as we look at our curriculum going forward, we have to stop saying we're primary care musculoskeletal providers, which a lot of times we hear, or primary care neuromusculoskeletal providers. We are primary care providers, period. Let's just get over it. Primary care providers. But if we're primary care providers, we're different. We offer a different, we're not medical primary care providers. And I don't want to do that because it's been a failed system that we're not getting healthier. We're not healthier this decade than we were last decade. We're worse. So if we're going to continue to be at the altar of medicine, then I think we have failed our role to ourselves, but more importantly, our role to society. So if we are primary care providers, we need to think more in terms of lifestyle medicine. I'm going to throw some terms out: integrative, holistic health, lifespan health, doing basic blood, stool, urine testing, basic testing to look at what is actually in the body and what is being used and not used. Nutrition, fasting, caloric counseling, basic level of counseling that we can do, behavioral coaching, anxiety management. I don't know if we teach, we have to actually understand anxiety. We have to actually be able to conduct and perform and teach people how to do that within our student body. So when 40% of our students have significant anxiety. So I think it's important that we teach and model and allow people to do that. And of course, sleep coaching. So that's what we do when you see the physical therapist. That's the primary care model that we provide to society. The modern medical and agricultural industries have created, promoted, and sustained an epidemic in pain, obesity, and chronic disease. We are once again called to lead in the midst of societal strife and a pandemic. Here we are in our next 100 years. We don't have that much time. We need to pivot. We need to pivot strong, and we need to pivot hard. And we need to get back to the business of health care, which really is about care. And what I'd like to do now is just thank each of you for being in the right profession at the right time. And I'd ask you to just take a deep breath as we look out in this beautiful day, in this beautiful room that I'm honored to be the first to speak in. And think about that patient. There's many of them, but perhaps it's that first one that literally you changed their trajectory of their life. And they still stick with you and you say, yeah, that's why I came into this profession. So just sit back and think about that while we I do have one person I'd really like to thank because rarely do I get to do this. So just one last slide. I thank my family, but most importantly, I need to thank someone who I wouldn't be here if she hadn't woke me up during PT classes as I dropped my pencil, in Marquette back when I was probably too young to be there. But she's, got me through PT school. She's been my business partner, my lifelong PT colleague and mentor, and clearly a public speaking critic. This is a lot better, I can tell you. And most importantly, above all, the one I still laugh with, dream with, and love, my wife, Sue.
Tim, that was a fantastic talk, and I hope everybody enjoys the festivities over the weekend. Thank you very much for coming.
Thank you so much. Really appreciate it. Thank you very much.